Thank you for the opportunity to present today. I am going to be presenting on working towards home diagnosis of obstructive sleep apnea in children with Down syndrome, the Sonomat, a pilot study. My name is Dr. Jasneek Chawla, and I'm a paediatric respiratory and sleep physician at the Queensland Children's Hospital in Brisbane, Australia. So just by way of background, in Australia, 1 in 1,100 babies born will have Down syndrome. This accounts to about 290 babies born each year in Australia. Down syndrome is the commonest genetic cause of intellectual disability, but there are wide phenotypic differences in cognition and behaviour. In recent times, the role of sleep has been proposed to account for some of these phenotypic differences. The reason for this is that sleep disorders are very common in Down syndrome. Poor sleep is recognised to have negative effects in children in general, and it's likely that children with Down syndrome are even more vulnerable to these effects due to their existing intellectual disability. So there is potential that if we can improve sleep for these children, we may be able to improve their outcomes. Just by way of summary, the sleep problems we see in children with Down syndrome include non-respiratory sleep problems, which are highly prevalent but are often underreported, and you can see some of those listed here. And sleep-disordered breathing. Children are predisposed by their phenotypic features, which include the flattened midface, large tongue, hypotonia, amongst other anatomical features. It is also exacerbated by comorbid conditions, such as obesity, cardiac disease, and hypothyroidism. Overall, obstructive sleep apnea is about 6 times more common in children with Down syndrome than those with typical development. The diagnosis of OSA is made with a sleep study or polysomnography. The key investigation for diagnosis and quantification of severity of OSA is therefore this sleep study. This involves quite intensive monitoring with lots of leads. See here the list of the different leads that are placed, including audio and video recording of a child. And here is a child with Down syndrome undergoing a sleep study. This can be quite distressing for some children, especially children with developmental delays, such as those with Down syndrome. The test itself is very labour intensive and requires skilled paediatric staff who can place the monitoring and ensure that children remain safe during the night. A specialised lab environment is required for all the technical monitoring that takes place. The interpretation of polysomnography is also challenging in children. The scoring criteria for sleep studies is based on adult patterns of OSA and therefore not always reflective of disease severity in children. The main measure, the apnea-hypopnea index, does have limitations therefore in children. Here is an example of a sleep study in a child with Down syndrome that shows severe obstructive sleep apnea. You can see on the left-hand side of the screen here, an overview of the whole night's sleep, including the saturation profile, which shows these dips in oxygen levels, the rise in heart rate associated with those, and the rise in carbon dioxide that we see on our monitoring. If you look at the pattern on the individual epoch here, you can see that this child is having multiple episodes where the airflow ceases, the breathing pattern continues, and there is desaturation. These represent obstructive events which occur frequently in this child over the course of the night. Unfortunately, it's not always as perfect as that. This slide here shows that recording in children with Down syndrome can be difficult. Here we have no flow recording because the child did not tolerate the nasal flow and also did not tolerate the thermistor, which we often use as a surrogate measure of flow in children. Similarly, in this one, this child didn't manage to keep the EEG leads, the head leads on, or the eye leads, or the flow, or the thermistor. So we really end up with very minimal information. This is just some snapshots of a report from a child with Down syndrome, and this is the tech report reported by our nursing staff who attended the study overnight. You can see here that the child was very distressed during setup. They did not tolerate the leads, and there were multiple technical interventions through the night to try to replace the bands and the cables. Obviously, this led to sleep fragmentation, and the whole thing was made worse by the fact that the mother was also snoring through the night. In the morning, the child was distressed and reluctant to be touched by the nursing staff, but happy with the mother. And this is just to highlight how difficult and distressing these studies can be. So therefore, we need some alternatives. Ideally, we need a non-invasive and better tolerated type of monitoring, something that is easy to use and less labor intensive. Ideally, it would be good to be able to undertake it at home to put less burden on hospital resources, which is certainly a consideration during a pandemic. We need measures that are more reflective of pediatric sleep disordered breathing, such as a better measure than the apnea-hypopnea index, and that can help us to predict treatment outcomes. And of course, it needs to be affordable and accessible. The Sonomat is a new device that has been developed by this man here. This is Professor Colin Sullivan, who is the mastermind behind CPAP, which was developed many years ago. Professor Sullivan has developed this mat, which is known as the Sonomat. It sits under the child's bed sheet on top of their own mattress. The Sonomat contains 4 identical sensors within the foam, which each record movement and acoustic sound. You can see here the location of the Sonomat sensors. There are also 2 room microphones. So each of these sensors records the same data, allowing the subject to move around the bed unrestricted. You can detect apneas and hypopneas in a similar way to how we do on a sleep study, using the movement and the breath sounds. Importantly, it provides a continuous measure of obstructed breath sounds, which is something that the sleep study actually lacks. And this is more typical of what we see in children with obstruction. It also measures body movements, so it gives us an idea of sleep duration and fragmentation. This has been validated in 2 previous studies in typically developing children. They've developed a scoring system that was designed similar to sleep study scoring guidelines, and therefore the 2 can be compared. The Sonomat has been shown to accurately diagnose sleep disordered breathing in children using the current metrics. It permits quantification of partial airway obstruction in addition, and it also helps you to quantify snoring and stertor, which is common in children who have obstruction. So our study is basically to look at whether the Sonomat is feasible for children with Down syndrome, to compare it against sleep studies that are done in these children who are being evaluated for OSA and sleep disordered breathing, and to evaluate the family's experience of undertaking this home monitoring. And today I'm going to share with you some preliminary data. We have included children with Down syndrome who are aged 2 to 16 years, who are eligible for the study if they are requiring a diagnostic sleep study to evaluate their sleep disordered breathing. These children undergo a concurrent Sonomat monitoring at the same time as having their lab study. They then take the map home and do 3 to 5 nights of home monitoring with a sleep diary. The families also complete a questionnaire about their experience. We then have the study endpoints include comparing the individual respiratory events from the sleep study and from the Sonomat. Using a measure similar to the AHI from the Sonomat, we compare the 2. We also compare their additional sleep parameters and of course look at the survey results. So this is preliminary data on our first 10 patients. We had a 50-50 split of males and females. You can see here their coexisting comorbidities. You can see their age, which is around 7 years, and you can see their BMI. So overall, we've had pretty good results. We had a couple of failed recordings with the Sonomat, which was generally, which was also within the lab, wasn't actually at home when the mat was forgot to be put on. And generally, these parents reported that it was easy to use. Parents generally felt the Sonomat was a good option instead of sleep studies in the hospital, and they all graded their experience of using the mat as excellent, very good, or good. You can see here a comparison of parameters that we use on a sleep study: total sleep time, sleep efficiency, apnea-hypopnea index, obstructive events index, central events index, and arousal indices. And you can see here the corresponding values from the Sonomat. The measures were actually very comparable, suggesting that the Sonomat is picking up similar to what a formal sleep study will. The only real difference was with our arousals, and this is likely to be more on the Sonomat due to movement being detected more easily. This is comparing using a visual method, so you can see the apnea-hypopnea indices here, the obstructive events index and the central events index. And overall, these are actually quite comparable on both forms of monitoring, which is quite exciting for us to see, because it suggests that the Sonomat may be something that can be used in the future. Here you can see the pattern in our 10 children according to age, and what their obstructive indices were like, the apnea-hypopnea index on both measures. So again, this is just showing the comparison and how closely they were recording. Additionally, on the Sonomat, we get these additional parameters. We can get snore events, and you can see that the Sonomat can quantify how many snores we have, the total snore time, and the percentage of time that the child is snoring through the night. It can do the same with Sterta, and this is quite important. The importance of this I'll just highlight with some of these patients. Here you can see that on a sleep study, we had a low apnea-hypopnea index. Anything under 1 is considered quite low. Similarly, we had a low apnea-hypopnea index on the Sonomat, but there were 208 snore events for this child. The child was snoring for 20% of the study, therefore suggesting the Sonomat is picking up something that we don't see when we look just at this measure. Likewise, in this child was snoring for 23% of the study. So in summary, our preliminary results show promise. The Sonomat appears to be safe at home, easy to use, and well tolerated by children with Down syndrome. And this could potentially extend in the future to other disability groups. So far, our respiratory parameters appear to be comparable between the PSG and Sonomat. The Sonomat also seems to provide us with some additional measures, such as Sterta and snore, which will be important, particularly in children in whom the apnea-hypopnea index is low. The Sonomat also seems to detect more movement and arousal, and this could be related to snore and Sterta that we're not seeing on a sleep study. To date, we've recruited 30 participants. Our target is 100. We plan to further refine our analysis and look at corresponding sections of monitoring with no interpretal data on both the PSG and Sonomat and exclude these so that we can see whether our measures are even more comparable. And in the future, we also hope to perform studies in other children with neurodisability. I'd like to thank the families of our children with Down syndrome for participation, our department at the Children's Hospital in Brisbane, my research team, and Professor Colin Sullivan and his team, with a special mention to Dr. Mark Norman for supporting the scoring of this study. I also like to thank my statistical support and my funding bodies. And I'd be happy to take any questions.